Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to the second session, the Retina session of the first competition in iTeach program. And I would like to thank very much the board members who gave valuable time, a very important part of their valuable time, and being with us to assist to make this program successful and to support the young ophthalmologists. And I would like to thank very much the competitors, the speakers, the 9 speakers who did their best in order to be on high standard. Of course, I'd like to welcome and thank all the attendees who are attending with us tonight. Our first speaker will be Dr. Rana Dahan. She will talk about the anti-VEGFs in vitreoretinal practice and a new anti-VEGF. Of course, she will mention if there is any financial disclosure. I would like to thank Dr. Suzanne Amana and Dr. Musa Al-Fuqaha for taking the role of discussing with Rana. And let us start. Bismillah. Of course, you know the rule, everybody. 12 minutes. It is clear, yes.
It can move or not? It can move or not?
It can move, yes. So 12 minutes for the presentation and 3 minutes for discussion. Sorry, 5 minutes for discussion. Thank you very much. You can start.
Thank you, Dr. Mazen.
Good evening. It's a great honor to present our topics in front of our seniors. So thank you for this opportunity. My name is Rana Dahan. I'm a general ophthalmologist from Yemen. And my topic anti-VEGF in vitreoretinal practice with a brief introduction for prolizumab. So I'll start with introduction. I have no financial disclosure related to my lectures. VEGF, it's abbreviation for vascular endothelial growth factor. Its history back to early 1970s, according to the American Journal of Pathology. Then in 1980s, there was an identification, purification, cloning, and obtaining this crystal structure of VEGF. Then in 2004, the first anti-angiogenic drugs in form of avastin was approved by Food and Drug Administration for treatment of colorectal carcinoma. As a structure is considered of single protein that's secreted during hypoxia, and there is 5 type ligands of VEGF identified in human being in form of VEGF-A, P, C, D, in addition to placental growth factor. And the most important one for us in ophthalmology is called VEGF-A, which play an important role in angiogenesis related to diabetic retinopathy and neovascular age-related macular degeneration. Those factors to act, it must bind to specific receptor in form of VEGF receptor 1, 2, 3 to form VEGF receptor complex or system, as shown here. So any molecule would compete with the VEGF to their binding receptor site, they will block the VEGF action, and those molecules known as anti-VEGF molecule. Again, at the level of the retinal cells, angiogenesis started with hypoxia that lead to VEGF receptor expression at different retinal cells, followed by binding and intracellular signaling that lead to cell proliferation, migration, and new vessels formation. Those new vessels are leaky, lead to retinal cell swelling and retinal cell dysfunction. So the anti-VEGF molecule will block this process and prevent retinal cell dysfunction. As an example of those anti-VEGF molecules, we have a lot that inhibit powerfully the VEGF-A in form, but the most commonly used here, we have bevacizumab, ranibizumab, and aflibercept. They differ from each other in terms of their physical properties like structure, molecular weight, half-life, affinity, in addition to their cost. As an example, they have as a structure ranibizumab considered as a fragment antibody, bevacizumab considered as an whole antibody. Meanwhile, aflibercept that's considered as a fusion protein that can trap VEGF inside, so it's called VEGF trap or Zali-trap. So why we are talking about anti-VEGF today? Because it becomes one of the more frequently applied treatment modality in vitreoretinal practice. In addition, it has the following properties. In form, they consider as a less invasive procedure. They have less cost, short learning curve in compared to surgical intervention. They are repeatable and always available all over the world. So before 2004, there was different retinal modality for treatment of retinal disorders like cryotherapy, laser, photodynamic therapy, in addition to vitrectomy. After that, anti-VEGF introduced to be one of the choices for treatment of wide spectral retinal diseases. Then after a while, it became the main treatment of choices for different retinal diseases as following: as diabetic retinopathy, neovascular age-related macular degeneration, corneal neovascular membrane, macular edema, ROP, cause disease, LZs, in addition to anterior segment neovascularization. And there is many clinical trials that prove their efficacy in treatment of those diseases. For example, we have RAID and RAISE study that prove their efficacy in treatment of diabetic macular edema. And we have PRAVO and PROSE study that prove their efficacy in treatment of macular edema, post-central and branch retinal vein occlusion. In addition, we have an ANCHOR study that prove their efficacy in treatment of neovascular. So up to date, we have more than 340 clinical trials.
Excuse me. Yes, please go back to the previous slide because your voice was interrupted.
Okay. So up to date, we have more than 340 clinical trials that are regarded to anti-VEGF treatment that just registered in one clinical research gate, which is clinicaltrials.gov. Here we have a patient with neovascular age-related macular degeneration. The OCT shows presence of intra-subretinal fluid. That patient had an anti-VEGF injection. Then after 1 month later, the OCT shows complete resolution of all those fluid. So coming to the regime for treatment with anti-VEGF, we have 3 regime for anti-VEGF treatment, which is the fixed monthly injected regime. This patient will be injected every month, but that type of regime is not practical as the patient will be more liable for infection. The second is called Pro-Renata or PRN regime. In this regime, patient will go initially through 3 initial doses of anti-VEGF 1 month apart, then follow-up will be also re-injection can be as needed. The third is known as treat and extend regime. In this regime, patient will be injected for the first time, then the follow-up will be extend or shortening according to the patient's stability, improvement in the best corrected visual acuity. Also re-injection can be as needed. So patients who gain in terms of best corrected visual acuity 5 letters and more and improve the central subfield thickness, the central 500 micron, the OCT by 10% and more, those patients can be said they are improved after anti-VEGF injection. The other, they are not and need to be re-injected again. Also, in terms of follow-up of those patients, we have the OCT, the ocular coherence tomography, that not only can detect or diagnose, it can also determine the central subfield thickness. So for follow-up, in addition, it can predict the response for treatment in cases of diabetic macular edema, as it can show some biomarkers that can help us, such as the presence of hyperreflective retinal foci, intraretinal cystoid spaces, intraretinal bridging spaces, presence of disorganized inner retinal layer, the presence of disruption of the outer photoreceptor segments, in addition to the status of the retinal thickness and subfoveal choroidal thickness, in addition to presence of hard exudate. So all these points can help us to predict how the eye gonna respond to anti-VEGF treatment, pre-anti-VEGF injection, as shown in details in the British Journal of Ophthalmology in 2020. So coming to the contraindication, patient who is allergic or pregnant, lactating women, in addition to recent ischemia, either cerebral or myocardial, they are contraindicated to be injected with anti-VEGF. And most common challenges during practicing with anti-VEGF is patient dissatisfaction, especially with repeating doses, in addition to loss of follow-up with those patients. So in terms of improving patient satisfaction, we have a new type of medication with anti-VEGF, which is called brolucizumab. It's considered a single-chain fragment antibody. It has a high affinity, rapid clearance from circulation. It powerfully inhibits VEGF and its isoforms. In addition, it can be injected every 3 months rather than every 1 month or 2 months. And this is its efficacy approved by 2 studies. They are Hawk and Harari studies. They are identical studies, but they had done in different countries. They compare the efficacy of brolucizumab to the aflibercept in treatment of neovascular age-related macular degeneration. So both groups, the first group injected by brolucizumab 6 milligram every 3 months, and the other group injected by aflibercept 2 milligram every 2 months, and the result was plotted in the following. The upper graph for Hawk study and the lower for Harari studies. We have the blue line for brolucizumab and the green for aflibercept. In terms of best corrected visual acuity, both group has improved in compared by brolucizumab to aflibercept, and brolucizumab was not inferior to aflibercept in terms of improvement by follow-up of this patient up to 48 weeks and can maintain the efficacy up to 96 weeks, which is the end of the study. In terms also of the central subfield thickness, both group has improved, and brolucizumab also again was not inferior to aflibercept in terms of improvement. So in addition also to the long-acting anti-VEGF, which is the brolucizumab, we have a port delivery system, which is new as implantable anti-VEGF. That type of BDS has a longer duration, up to 6 months, and can refill again for another 6 months. That could help us in decrease patient frequency for injection, increase the duration of anti-VEGF medication, improve patient adherence to the treatment, in addition, help patient and improve patient life quality. This type of PDS has approved by FDA in 2021. And lastly, coming to the new type of OCT, which is automated OCT analysis that has a high accuracy in compared to the retinal specialist diagnosis. That type of automated OCT can detect, diagnose, report diagnosis, so could help us as a general ophthalmologist in early detection, avoid missing cases, follow up for these cases for new activity, then refer to the retinal specialist as needed. So the using of automated OCT could be a powerful tool to be used clinically in the near future. In addition to ongoing researches that related to AI, the artificial intelligence enhanced technology that can early detect the neovascular age-related macular degeneration population. So early detection of those populations can help in early intervention with anti-VEGF treatment and prevent those patients from reaching the ending point, which is the macular scarring and neovascular age-related macular degeneration. So it will improve the result and improve patient vision quality. So let's take a home message. Anti-VEGF become one of the most applicable treatment modality in retinal practice that can treat retinal disorders successfully. OCT, a crucial tool that can detect, diagnose, predict the response, especially for diabetic macular edema patients. New long-acting anti-VEGF as protezumab, in addition to BDS, will hang over the retinal practice in the next decade and will improve patient adherence to the treatment. Artificial intelligence, enhanced technology and devices will play a role in disease early detection, so will help a lot in early intervention with anti-VEGF treatment. So as an ophthalmologist, our mission is safe patient vision, and many hopes could be realized in anti-VEGF era. So this is the reference, and thank you so much.
Thank you very much. That's great. And let's start the discussion. Now, each one of the board members will ask only one question for the sake of time. Let us start with Dr. Suzanne Amana.
Thank you so much, Dr. Rana. It's a perfect presentation and very interesting topic. Not only for the specialists, retina specialists, nowadays even general ophthalmologists, specialist ophthalmologists, they are dealing with the anti-VEGF. And I want to know the reference for your slide number 16, a classification of response or the treatment improved or not improved. Okay, can you tell me the reference that you depend on?
I think I referred it to one of the studies related to neovascular age-related macular degeneration, but I didn't remember the name of the
related to DME. Is a DME, not a wet AMD.
So yes, sorry, I didn't remember the because I just write it.
Like the good response or poor response.
Okay, I didn't remember it actually, but I just wrote all my research links for reference at the end of the slides, but I didn't remember which one of those reference. Sorry.
So after how many injections we can assess and to say the patient is a good responder or poor responder to treatment?
According to PRN, after 3 initial loading dose, I can assess the patient for the best-corrected visual acuity and central subfield thickness.
After 3 loading dose. And this is applicable for diabetic macular edema and wet AMD as well, because you mentioned the 3 regimes without saying yes. For which. Okay, the regimes
yes.
applicable for both. So the
yes.
loading dose for both?
Yes, for both. In addition, even the central retinal vein occlusion also include this type of regime, which is treat and extend. Also the PRN has the same regime. Neovascular age-related macular degeneration, diabetic macular centrally involved, in addition to central retinal vein occlusion, one of the protocols going with PRN, also with treat and extend regime, as I read.
Okay, thank you.
Thank you.
Thank you, Dr. Suzanne. Done, Dr. Suzanne?
Yeah, done.
Okay, great, thank you. Dr. Musa.
Thank you, Dr. Rana, for this excellent presentation. I want to ask you, I don't know if you're aware of the side effects of brolucizumab, because many retina surgeons now, we're talking about we should use this medication or not, or we should not use it, because many institutes now stop to use this medication. I don't know if you're aware of any the major side effects that prevent us from using it.
Yes, brolucizumab was the FDA approved in 2019. Before that, there was a cases reported with the thromboembolic cases, but they are referred to because it occurred during 2019 in Corona time. There was an interaction between that and the Corona side clinical signs. But there is the thromboembolic, one of the side effects reported for brolucizumab. The second thing, in cases of uveitic eye, they are reported occurring of intraocular inflammatory process, so they are contraindicated to be used in uveitic eye. In addition, as a general anti-VEGF treatment, there is 1% that it will cause an uveitic-like syndrome or intraocular inflammatory response. It was very small risk, but it was very significant. So yes, there is unreported side effect for this medication.
Yes, excellent. Thank you.
Thank you very much.
Can I have a comment, Dr. Mazen?
Yes, very quick comment. Yes, yes.
I can give a comment only on brolucizumab, as Dr. Musa say about the side effect, and also I can't consider it as a long-acting anti-VEGF. They try to confine us that it is long-acting. It says not long-acting. I try it and I have many side effects from it, and I stopped trying it. Thank you very much.
Yeah, thank you very much, Dr. Muhammad Abdullah, for being with us and for this valuable comment. Thank you, Rana. Now we will move to the second speaker, Iman. She will talk about pneumatic retinopathy. Dr. Ala Din and Dr. Rashid will discuss with you, and you can start your presentation, please. Dr. Iman is with us.
دكتورة إيمان عندها مشكلة بسيطة في النت.
Okay, so we will move to Dr. No problem. Dr. Rawan. Yeah, Dr. Rawan is here.
Yes.
Dr. Rawan, idiopathic multifocal white dot syndromes. Dr. Maha Youssef and Dr. Bara Qubaisi will discuss with you. So would you please share your screen? Just a second, maybe I have to give you the permission. Yes, you can share now, please.
Please tell me when it's obvious.
Did you share or not yet?
Yes, I'm sharing. Host disabled participant screen sharing. It gave me like this. You disabled me.
No. Everyone
okay,
is in.
Okay, I will try again now.
Now, all panelists, I would kindly request you to evaluate using the sheet. There are two tables, one for the same specialty and the other one with the but without this specialty, please. So I think there is a financial interest with this picture.
I have no disclosure.
All right. So start, please. The timer will start now.
Okay, good evening, everyone. It's my honor to be with you today. I am Dr. Rawan El-Dweri, third-year medical ophthalmology resident at Ministry of Health, Jordan. Thank you. Special thanks for our professor and the panelists for your precious time. It's appreciated. My topic today will be about idiopathic multifocal white dot syndromes. Okay, I would like to start my presentation with two questions. The first one, is every whitish chorioretinal lesion is considered as a part of white dot syndrome? The answer is no, because there are many infectious and non-infectious inflammatory diseases may present with with multifocal whitish chorioretinal lesions. I am sure that one of them at least is in your mind now, such as syphilis, tuberculosis, sarcoidosis, sympathetic ophthalmia, VKH, intraocular lymphoma, pneumocystis carinii choroiditis, candidiasis, dozen, ocular histoplasmosis syndrome, and even drusen. Okay, the next question. Is every white syndrome lesion can come with whitish chorioretinal lesion? The answer is no, because we have azure that can come with no significant lesion at the time of a presentation while the patient is complaining. Okay, what are white dot syndrome? They are a particular group of idiopathic disorder characterized by the presence of whitish lesions and inflammation of the outer retina, RPE, choroid, or combination of these layers. Okay, there are 8 subgroups that I will go through them in brief, but please allow me to use the abbreviations to save time. BCR, MCP, PIC, SFU, mutes, ABMP, serpiginous choroidopathy, and azure. How to distinguish between white dot syndrome? We can distinguish one from another based on the appearance or the distribution of the lesions, the clinical course, or patient variables such as age, gender, laterality, functional, and image examinations. My aim from this presentation is to review the distinctive and shared features of the white dot syndromes, highlighting the clinical findings, diagnostic test results, proposed etiologies, treatment, and prognosis. Let me start with bare-shot retinopathy. All of white dot syndrome come with the same picture of patients, and I'll mention the exceptions. I mean bilateral, white women, middle-aged. For BCR has a high association up to 97% with HLA-A29. Symptoms for all white dot syndromes also because they are affecting the retina, decreasing vision, nyctalopia, photopsia, decreased color vision, and floaters. Here in BCR, symptoms can precede the onset of classic fundus findings by several years. BCR examination, anterior segment inflammation may be minimal or quiet, which means no posterior synechiae and no KPs. Vitritis here is common. The lesions are multifocal, hypopigmented, ovoid, cream-colored lesions that size half to quarter disc diameter, typically distributed nasally and inferior to the disc. Complicated may be by vasculitis or narrowing of vessels, periphlebitis. CMO also here is the main cause for vision decrease. Criteria of diagnosis for BCR, as we mentioned, but please let me stress on exclusion criteria. If there is KPs or posterior synechiae or later on pigmented scar, this can exclude the diagnosis of BCR. Imaging here lets us agree that all white dot syndromes subgroups come in fluorescein angiography with early hypo due to blockage, late hyperfluorescence due to staining. Exception for this rule are 2. BCR, which comes early normal fluorescence and late hyper, and mutes, as we will mention, that comes early hyper, late hyper. Here we can see in the pictures, early normal, late hyper, colored photo for fundus, and here can show disc leakage with periphlebitis leakage around the vessels if it's complicated. Here, autofluorescence depending on RPE damage. ICG also useful in BCR that shows a blockage in all these phases. Prognosis here is guarded. Remission and exacerbation can happen. Treatment also for all of white dot syndromes, we will start with the steroids, periocular, which needs a treatment. Okay, we will start with periocular or systemic steroids. If not responding, we can go for immunosuppressive agents such as methotrexate, cyclosporin, Celicept, which is mycophenolate. And if complicated by CMV, we will go for anti-VEGF. And I would like here to mention Retisert, which is sustained release fluocinolone acetonide that eliminates the need for systemic therapy because it will release corticosteroids up to 3 years. Here is a picture for Retisert, which is sclerally fixated intraoperative. MCP and SFU and PIC I will discuss them as one group because they are considered to be one group with some differences. MCP, from its name, pan-uveitis, that means vitritis here is a must. Anterior uveitis comes with up to 50% of the patients. Here also for active lesion of MCP, inactive lesions. As we agreed for fluorescein, early hypo, late hyper. Treatment also is the same here. Complications also here is the same, but the highest for CME. PIC, what is unique about PIC here? The absence of vitritis or anterior uveitis. And the highest rate for CMV also goes with PIC. The lesions here are small, yellow, white lesions in the posterior pool and mid-periphery. Treatment, honestly, is not necessary here. It's self-limited. Only if complicated by serous detachment, we can go for steroids. PIC also does not recur. Here is a color fundus for PIC, early hypo, late hyper, active vs inactive lesions. SFU also nothing to mention more, but I would like to mention that here also vitritis, not as PIC. PIC has no vitritis. Here also a picture for SFU, and also can be complicated by neurosensory retinal detachment. Okay, treatment for, fluorescein angiography here also early hypo, late hyper. Treatment here is not necessary because especially if fibrosis developed, has little benefit. Okay, now I will go for mutes and ABMP. I will discuss them together because they have something in common, which is the viral prodroma preceded by viral prodroma, and both of them has no treatment because it's self-limited only if complicated. Mutes, something is unique about mutes, that is the only one unilateral and also can affect the fovea, granular orange lesions at the fovea, as we see here in the picture. Also unique about mutes, as I mentioned, it comes early hyper, late hyper fluorescence. Prognosis is excellent within a couple of weeks, no scarring. APMP, what's unique about APMP that it affects both genders equally. And as I mentioned, influenza prodroma. And please let me tell you that FMP comes in early lesions, multiple yellow, white lesions situated primary at the posterior pool at the level of RPE. But within weeks, varying degrees of RPE atrophy and hyperpigmentation will occur, as we will see here in the picture, early vs late. The same complications, but here is a very important complication, especially if the patient of APMP comes complaining with neurological signs such as severe headache. We have to consider cerebral vasculitis, and here the treatment will change to IV methylprednisolone. Early hypo, late hyper in fluorescein angiography. Prognosis and treatment, it's self-limited only if complicated. Serpiginous choroiditis comes with patients above 40 and more in males. The lesions typically peripapillary area and spread centrifugally. Okay, the active lesions here shows hazy borders, and the inactive lesion shows sharp borders, as we see here in the picture. Active vs inactive. Serpiginous also shows early hypo, late hypo. Sorry. Autofluorescence here also for serpiginous. Prognosis and treatment also the same, but here depends on the proximity from the fovea. Azure, the patient comes complaining from decreased vision or photopsia, but no fundoscopic findings are there or very minimal. Later on, we'll show just like sectoral retinitis pigmentosa, and when we see them, we will say, oh yes, he was Azure. No treatment here is needed. Fluorescein also. Okay, summary approach to Wilder syndrome. First, please exclude the differential diagnosis that we mentioned first, the first slide. About age, If the patient above 40, think about serpiginous and pursuit retinopathy. Under 40, think about the rest of them. Gender, we have equality in Eb and B, serpiginous more in males, and the rest of them more in females. Laterality here, unilateral for mutes, bilateral for the rest of them. Myopic with the group of PIC, MCP, SFU, add to them mutes and azure. Large lesions here in serpiginous and Eb and B, small to moderate lesions in the rest of them. No lesion detected in azure. AC reaction here, we can see it in MCP. Vitritis is a must in MCP, also in Birdshot, but typically absent in PIC. Fluorescein, we have mentioned about fluorescein. Complications here, CMV goes with the highest percent for PIC, CME the highest for Birdshot, retinal vasculitis the highest for Birdshot, cerebral vasculitis, FMB. And here are my references, and thank you.
Great. Thank you for being on time. And now we will open the discussion. Dr. Maha.
Good afternoon, everybody. Dr. Rawan, this was an amazing for a third-year resident. This is very amazing presentation. The last few slides were very good. You have simplified the differential diagnosis between the different types. But actually, I would like you to, you have missed some new data regarding the white dot syndromes, and this is very okay for being a third-year resident. This is too much for you. But the SUN group, standardized uveitis nomenclature group, have revisited the diagnosis of many entities of uveitis, where including the white dot syndromes, and they have put them, I couldn't say new criteria, but this criteria you should read them. You will benefit a lot. Secondly, white dot syndrome, this terminology is stepping down those years in the last decade, because they have classified to choriocapillaritis and stromal, and they only
Dr. Maha, we cannot hear you.
should benefit a lot. Sorry?
Would you please, we didn't hear you. So would you please repeat that the terminology is changing now?
Yes, white dot syndromes are being stepping down as a terminology, and they have been reclassified into stromal choroiditis and choriocapillaritis. The Birdshot is the only one of them belonging to the stromal choroiditis, and the rest mostly with the choriocapillaritis. If you, I am recommending that if you can find these papers, and I can send you if you need, this presentation will benefit a lot from 3 or 4 slides at the very end of it to reclassify them according to multimodal imaging, ICG, and OCTA. But actually, I am very, very happy with the presentation. You have simplified things, and the last few slides were very amazing. And thank you very much, Dr. Rawan.
Thank you. White dot syndrome is made easy. That's my
Yes,
purpose.
this is a very, very, very difficult task to go through, and thank you.
Thank you very much.
Thank you, Dr. Maha, very much. Thank you. Dr. Bara.
Thank you, Dr. Rawan, for this wonderful lecture. As Dr. Maha said, it is brave to consider lecturing on this topic, because this is considered as an advanced topic in uveitis. I have a clinical question for you as a resident. How do you differentiate a lesion that is in the retina or in the choroid, and how do you measure the size? As you said, in PIC and MCP, there is a difference in the size. So how do you clinically measure the size of the lesion?
Okay, thank you. Depending on the first question, how to differentiate between retinal and choroidal, I think according to the blood vessels, as my level now, we will follow the blood vessels if the lesion is just at its level or in front. We are talking about retina. If the choroid, it's much deeper and deeper to the blood vessel and specifically. We can also use imaging in this to help us more, if not clinically. And depending on the other second question, sizes, we measure according to the optic disc if the lesion is large. If small to moderate, we can also depend on the caliber of the blood vessel or retinal vein. That's
Okay, great.
Okay, fantastic. Thank you very much, Dr. Rana. So now we will move we'll go back to Iman. Iman has joined or not yet? Not yet, okay. So speaker number 4, Sashwanti, are you with us? Unmute yourself, Sashwanti, please.
Yeah, am I audible?
Yes, and
Yeah.
would you please start your sharing your screen? And Sashwanti will talk about ultrasound B-scan for posterior segment. Dr. Muhammad Abdullah and Dr. Suzanne Amana will discuss with you. So
Okay.
please start.
Thank you so much. At the outset, I would like to thank the professors for being here and looking over our presentations. With my presentation, I'm going back to the basics and revisiting the fundamentals of an important diagnostic procedure, which is not only important for retinal doctors, it's also important for anterior segment surgeons. So it is crucial to familiarize ourselves with the proper technique for performing an ultrasound and why we perform it and the common findings that we see with this examination. So let me start. So let's take a look at the physics of ultrasound. Two important things to remember are two terms called acoustic impedance and echo. The acoustic impedance is the ability of a medium to resist the transmission of ultrasound waves by virtue of its density. So denser the medium, the slower the velocity of the sound. Echo is part of a sound wave which is reflected back towards the source of the emitted energy from the interface between the two media. It is created at the junction of the two media with different acoustic impedance. So the greater the difference in the acoustic impedance of the two media, stronger the reflection of the sound wave. So this is what the ultrasound is based on. So the principle of ultrasound is what is shown here. An electric pulsar source generates an oscillatory signal. The piezoelectric crystal in the transducer is stimulated, and the resultant sound wave is projected onto the ocular tissue. Onto the ocular tissue. So once this is reflected, the reflected echo is collected by the transducer and is received by the receiver, which has an amplifier where the echoes are amplified. And there's a 2D display of the tissue on the monitor, which is the ultrasound B-scan that we see. So what are the indications? There are indications which are in opaque ocular media and clear ocular media. So in the opaque ocular media, in anterior segment, if there's a corneal opacity, pupillary membrane, dense cataracts, or non-dilating small pupils, or hyphema or hypopyon, or in the posterior segment where we cannot look through the media, such as in vitreous hemorrhage, dense vitritis, retinal detachments, or in case of intraocular foreign bodies or trauma. In clear ocular media, we can examine the anterior segment by certain type of scans for diagnosis of iris and ciliary body tumors. For the posterior segment, to look at the type of retinal detachment, whether it's exudative or egmatogenous, for intraocular tumors, size and location, dimensions, and for follow-up, and for optic disc anomalies, as well as choroidal detachment to differentiate between serous and hemorrhagic and posterior scleritis. It's also useful in ocular trauma and for localization of IOFP. So it's important to familiarize ourselves with the parts of an B-scan, especially what the probe marker is. Probe marker is, as you can see, this is a picture of a probe, and you can see this depiction here, which is suggestive of the probe marker. The probe marker is important because it gives us an orientation of the scan. So the probe marker always points to the top of the scan. So for example, if the probe marker is pointing nasally, the nasal is top of the scan, and a probe marker is pointing superiorly, superior is top of the scan. So this is an important point to remember while we're doing an ultrasound B-scan. The other important point is patient's ocular direction. Wherever the patient is looking, the whole scan covers that area. For example, if the patient is looking superiorly and we're doing a transverse scan, the whole scan, the picture of the scan covers the entire area. So we usually do ultrasound in reclining or supine position. However, sitting position is used in certain indications such as in silicone oil or gas-filled eyes, or to check for shifting fluid in exudative attachments. The probe is placed over the conjunctiva or the cornea or with the eyelids closed, and a coupling jelly is used with the probe. Image documentation should be both stationary and dynamic. And we look at special examination techniques such as the topographic technique where the location, extension, and the shape of the lesion is determined. Quantitative where the reflectivity, the internal structure, and the sound attenuation is seen. And kinetic where we look for the after movements, the vascularity, and the convection motion of the lesion. There are three types of scans that we typically do. One is the axial, the transverse, and the longitudinal. The axial is directed towards the center of the lens and the optic nerve. The transverse is the most commonly done one, which gives us the lateral extent, that is the 6 hours, clock hours are covered, and the longitudinal, which gives us the radial, that is 1 clock hour, and the anteroposterior diameter. For a routine screening B-scan, we usually do 4 transverse scans, that is, which scans the superior, nasal, inferior, and temporal retina, plus 2 axial scans, that is the horizontal and vertical. Longitudinal scans are done only in certain indications when we see a particular lesion or in regions such as retinal tears. So let's see how the axial scan is done. So the axial scan is done with the eye in the primary gaze. The probe is centered on the cornea like seen here. The probe marker is kept horizontal. If you want a horizontal axial scan, the probe marker is kept nasally. And if you want a vertical axial scan, the probe marker is kept superiorly. In the horizontal axial scan, you can get a scan of the macula, and thus you can measure the axial length in that scan. Whereas in the vertical scan, you will be looking at the superior and inferior to the optic disc, and you will not be able to measure the axial length. The axial scan is sound beam is directed to the center of the lens and intersects the optic nerve. In the transverse scan, the eye is in the direction of the interest. The probe is parallel to the limbus on the opposite side, and the probe marker is superiorly placed for nasal and temporal scans and nasally placed for superior and inferior scans. This is by convention. You can choose whichever you like, but you always have to remember where the probe is pointing before you interpret the scan. So as I explained before, the transverse scan, 6 clock hours are examined and gives a lateral extent of any lesion. The longitudinal scan, the eye is again in the direction of the interest, and it gives us 1 clock hour, that is the anteroposterior extent. The probe is placed perpendicular to the limbus on the opposite side, and the probe marker is directed towards the limbus. So this is how it's done. The probe marker is perpendicular to the limbus at any clock hour and gives us exactly 1 clock hour and the anteroposterior extent. The limbus to the fornix approach is a technique to examine from the posterior pole to the periphery. The probe is swept from the limbus to the fornix, and the limbus scan will give us the posterior pole region, and the fornix will give us the anterior periphery. This is an important scan to do, especially when we're looking at any kind of tumor or intraocular tumors, or if we're trying to localize an intraocular foreign body. First, we need to know the normal posterior segment scan before we go on to abnormal. The first echo is the lens echo, which is an overly highly reflective structure. The vitreous is usually echolucent. The retina, choroid, and sclera is a single high reflective structure. And the optic nerve head is a wedge-shaped acoustic void in the retrobulbar region. Anything which is different from this might classify as abnormal, but we'll look at them one by one. So one of the common findings that we can find is asteroid hyalosis. In asteroid hyalosis, there's multiple homogeneous, densely packed, medium to high reflective dot echoes with a clear space between it and the retina. So this clear space and this configuration might point us towards asteroid hyalosis. In vitreous hemorrhage, as you can see, there's no clear space. There's multiple low reflective mobile dot echoes and short lines in the vitreous with low amplitude spikes on the A scan. So there's low amplitude spikes, but with organization of the hemorrhage, the membranous opacities will become high with a higher reflectivity. And with dense hemorrhages, there'll be increase in opacities with higher reflective echoes. So the vitreous hemorrhage scans depends upon how fresh or old the vitreous hemorrhage is. But however, clinical correlation is important because, let's go on to the next slide. where we can see endophthalmitis sometimes can be, if it does not have typical anterior segment signs, it can be confused for vitreous hemorrhage. But there are certain differences. So it can have similar echogenic appearance to vitreous hemorrhage. However, loculations can occur as seen in this scan. Endophthalmitis also has typically a retinochoroidal thickening, which you can see in the scan below. A few differentiating points are PVD, that is posterior vitreous detachment, is more extensive in vitreous hemorrhage, and inflammation is more evenly distributed, whereas vitreous hemorrhage settles inferiorly due to gravity with layering of blood. Posterior vitreous detachment is a low reflective membranous echo, as you can see here. An incomplete one will have attachment to the optic nerve head, whereas a complete freely mobile one will not be attached to the optic nerve head. It has good after movements. In this scan, you can see possibly a blood-lined posterior vitreous detachment, which has moderate to high reflectivity, but good after movements. A rhegmatogenous retinal detachment usually have high reflectivity. It has a typical high A-scan spike. It has an attachment to the optic nerve head. The extension will depend upon which quadrant. For example, this is not a total retinal detachment, it's a subtotal retinal detachment. And usually it will persist in low gain. There are also two other types of retinal detachments, that is exudative and tractional. Exudative will have typically shifting fluid, that is, we need to look at the patient in supine and sitting position to see if there's any difference in the fluid levels. And tractional will have a concave configuration with areas of vitreous adhesions and traction. Choroidal detachment is a smooth dome-shaped and highly reflective membrane. As you can see, there's no attachment to the optic disc and typically no mobility. A double high spike called M spike can be seen on A scan. Serous choroidal detachments have an echolucent space behind the membrane, whereas hemorrhagic choroidal detachments will have multiple moderate to high reflective dot occurs behind the membrane. It is very important to differentiate PVD versus RD versus CD. So PVD, complete PVD is not attached to the optic nerve head, whereas an incomplete PVD is attached to the optic nerve head. RD is always attached to the optic nerve head, and CD is never attached to the optic nerve head. The PVD is low to moderate reflective membrane with a corresponding low to moderate A-scan spike. The RD will have a high reflective membrane, which is 100% reflectivity with a corresponding high A-scan spike. And the CD will have a high reflective membrane with a double or M spike, that is the retina and the choroid on A-scan. The PVD will disappear in low gain settings. RD will persist in low gain settings, and CD will also persist in low gain settings. PVD has typically good after moments. RD will have poor after moments, and CD will have no moments. Intraocular foreign body is another important indication of ultrasound, and also especially for medico-legal reasons as well. There's a dense, bright opacity with acoustic shadowing. As you can see, there's a shadow behind of ocular orbital structures. It's an extremely high reflective echo. And in spherical foreign bodies, you can find reverberations. It always persists in low gain settings. Tumors are also an important reason for ultrasound. Commonly seen tumors are choroidal melanoma and retinoblastoma. A choroidal melanoma might have a typical mushroom-shaped, dome-shaped mushroom appearance. It has a low to medium internal reflective echoes with sound attenuation and regular internal structure. It also shows internal vascularity and a collar stud pattern and something called acoustic hollowing at the base of the tumor. So it can have associated serous or exudative retinal detachments. Retinoblastoma is typically has an irregular contour and a high surface reflectivity. It has internal medium to high reflective echoes, and it typically has internal calcification with orbital shadowing, and it may be associated with retinal detachment. So these are the few of the findings. There are other things we can also see in ultrasound. I just covered a few of them. But let's come to how to report an ultrasound. So whenever we see a patient, as we're doing an ultrasound for, it's important to know how to report the ultrasound, and especially, like I said, in IOFB, because they're medical legal cases. So first you mentioned the area of interest. Then you mentioned the position in what you're doing the scan, whether it's sitting, supine, or prone. Then you mentioned the first structure, whether it's a lens, IOL reverberation or anti-reverberation echoes. Then talk about the vitreous or vitreous cavity, retina status. Yeah, almost done.
Time is over. Time is over. Okay, so you have 1 minute.
Yeah. So choroid status, optic nerve shadow, and the axial length, and always compare between both eyes. So take-home message is follow a systematic method of scanning and reporting. The clinical correlation is a must. Learn to differentiate between normal and abnormal, and always interpret a B-scan along with the corresponding A-scan, and always compare both eyes. Thank you so much for the opportunity.
You are most welcome. Thank you very much. And now we will open the discussion. Dr. Muhammad Abdullah.
Assalamu alaikum. Thank you, Doctor, for your great lecture. And you have an effort in this lecture. I have 2 points. The first point, I prefer you have more photo for this lecture. Every point you explain, you can explain it in photo. It is more better than the oral. The second, as a veterinary retinal surgeon, I ask you about the sensitivity of the ultrasound in diagnosis. Many of the problems that I have rely on the ultrasound on it. As non-diabetic vitreous hemorrhage, I rely on if there is a detachment, if there is a retinal break without detachment. What your opinion about the sensitivity of the ultrasound in diagnosis such condition?
It definitely depends upon if it's an opaque ocular media where we're not able to see the retinal fundus. It's definitely a little difficult to differentiate, especially if it's a long-standing hemorrhage. There's definite difficulty in differentiating between a retinal detachment and just probably a bloodline posterior vitreous detachment in diabetic retinopathy, diabetic hemorrhages. But if you're able to examine the fundus, and you always have to clinically correlate and see if your ultrasound findings are matching what you're seeing in the fundus. And so in those cases, I think clinical correlation, like I said, as my take-home message, is an absolute must in these cases. And we always have to err on the side of, if you're not able to see the fundus, always err on the side of maybe it could be a retinal detachment. It's also difficult in trauma, where we may not be able to always determine what the membrane can be.
Can you think that specificity or sensitivity of ultrasound can rise above 60 or 70% in diagnosis of such if I can't see the fundus? It's about 60%?
Yeah,
or
probably just around 70%, I would say. Yes, it may not be, but unfortunately, that's the only investigation we can do. We cannot do an OCT, we cannot do anything else. So that's the only investigation we need to rely on to go into the, to do the operation.
Thank you, Doctor. Thank you.
Thank you.
Thank you, Dr. Muhammad Abdullah. And now, Dr. Suzanne, please.
Good evening again. Really, Dr. Sashwanti is more than wonderful presentation for anterior segment and posterior segment ophthalmologist as well. And I may use this lecture as a reference for me in the future if I want to present about B-scan, if you agree. I have a short question. One of them, you said regarding the indication in a clear ocular media for retinal detachment, exudative or rhegmatogenous retinal detachment. What is the rule if there is a clear media and I can't see the detachment? What is the benefit of B-scan here? Can you explain to me?
So sometimes in bullous retinal detachments, you may not be able to see the retinal breaks, and they can also typically have an exudative component. So exudative will be typically bullous, whereas rhegmatogenous will not have a typical bullous component. So in this case, if you're able to find a tear, you can actually localize a tear with your longitudinal scans, then you can obviously err towards rhegmatogenous retinal detachment. So, and the other thing is, we can also look for, in case we're not able to see anything underlying in exudative retinal detachments, you can also look for tumors which might be causing that. So that's also an important, we need to do in these cases as well, just to make sure we're not missing out on any tumors which is leading to the exudative retinal detachment.
Okay, thank you. What is the second question, the preferred position of the patient to be examined? You mentioned 3 different positions. Which one the preferred position? Supine or sitting position? What is the preferred position for the patient to be examined?
Hello?
Hello?
Just a second. Maybe there is, okay. Just a second. Sorry.
Okay.
Yes,
Sorry,
Sashwant.
I wasn't able to say anything that time. I was in the attendees list. The preferred position, actually, the ideal position is actually prone position, but it's just not possible for all patients. We do supine position, but certain indications we do have to see, especially silicone oil-filled eyes. Prone position is an excellent position to look, because otherwise it's very difficult to examine the silicone oil-filled eye to see if there's any kind of retinal detachment or anything like that. So the supine, we follow supine position or a reclined position, but for certain indications like gas-filled, silicone oil-filled eyes and exudative retinal detachments, a prone position or a sitting position should be also done additionally.
Okay. And regarding the optic nerve anomaly, mention for us the most important pathology and how we can differentiate, or what are the specific ultrasonic findings?
Yeah. So I have a much longer presentation which covers almost everything, but obviously because of time, I have not included all these, but I have like a 50-minute presentation on ultrasound. So optic nerve head drusen is one of the best indications for B-scan ultrasound. It gives us a high reflective echo on the optic nerve, which can lead to, which also causes a backshadowing. And that's one of a very, ultrasound is one of the best methods to kind of detect an optic nerve ultrasound in pseudopapilledema. It can also be used in papilledema, where we can do, where we can see the optic nerve sheet diameter, and obviously optic nerve colobomas and glaucomatous cupping as well, where more than a cup disc ratio of 0.5, especially in opaque ocular media, we can detect on the ultrasound. So multiple indications for optic disc anomalies also.
Okay, great. Thank you very much.
More perfect if you add a few slides regarding the optic nerve finding.
I have it in my bigger presentation, just the short of slides that I couldn't. Okay.
Thank you, Suzanne, and thank you, Sashwanti. But there is a clear remark, no references at all in your presentation.
Okay. Oh, yeah.
All right. Okay. Yeah. So now we will move to speaker. We will go back to Iman. I think still Iman.
Still Iman is not ready yet.
Okay, so we'll go to speaker number 5, Kariman. Are you with us?
Yes, I'm with you.
Yes. Start sharing, please, your screen. Meanwhile, Kariman will present role of MFERG after blunt trauma. Dr. Musa Al-Fuqaha and Dr. Ala Ad-Din Abdin will discuss with you. Please start.
Okay. A second. First, I'm very thankful and grateful to all my professors and panelists for their time they spent to evaluate our presentation. Our presentation today is about role of multifocal ERG after blunt trauma case presentation. A 30-year-old man presented with left eye visual loss after blunt injury by football. On examination, there was mild hyphema in the left eye. Visual acuity 6/6 for the right eye and 1/60 for the left eye. Intraocular pressure was 18 mm mercury for the right eye and 20 mm mercury for the left eye. Fundus examination showed a localized area of prematurity at the superior nasal part of the macula. We prescribed it for him topical psychologic, topical steroid, antibiotics, topical anti-glaucoma, anti-fibrinolytic medication with bed rest and follow-up. 2 weeks after injury, the hyphema resolved and his left eye visual acuity improved to 6/36. He noticed scotoma at the inferior temporal visual field. Fundus examination revealed an area of mild retinal pigment epithelial atrophy at the site of prematurity. OCT macula showing a full thickness traumatic macular hole, as we see here. Multifocal ERG showed reduction in the retinal response density at the central macula with well-demarcated area of depressed retinal response density in the superior nasal part of the macula. As we see here, this figure illustrates the multifocal ERG printout. This is the topographic map. Try to make a pointer, laser pointer, okay. This is a topographic 3D map The central part showing decrease its retinal response density, and also there is also a localized area of the breast retinal response density as a superior nasal part of the macula. For this map, this is the trace area map. These waves showing decreased amplitude and delayed latency in comparison to these waves. He was observed and surgery was not performed to the macular hole as recommended by my supervisor, Professor Yoshiki Shimada. 6 weeks after injury, the left eye visual acuity improved to 6/9. And velocity macula revealed the spontaneous closure of the traumatic macular hole, as we see here. At 10 months after injury, his left eye vision recovered to 6/6, but still complaining of scotoma as a superior temporal field. Also, multifocal ERG showed the recovery of the retinal response density in the central macula due to closure of the macular hole. However, the well-demarcated area of the breast retinal response in the superior nasal part of the macula persists secondary to the damage associated with commerciality. And the multifocal ERG, as we see here, showing improvement in the retinal response density, the central part of the macula due to closure of the traumatic macular hole. But still, there is a localized area of the breast retinal response density. Previous studies have used OCT imaging in documenting the natural progression and the spontaneous closure of the traumatic macular holes anatomically. However, the functional changes following traumatic macular hole couldn't be assessed using OCT. Summary and conclusion. The use of multifocal ERG in our patient helped us to detect objectively the functional improvement after spontaneous closure of traumatic macular hole by the recovery of retinal response amplitude of the central macula. As observed in our patient's inferior-temporal visual field defect, which persists after the injury, corresponded to the area of commerciality. This was confirmed objectively by the well-demarcated reduction in the retinal response density in the multifocal ERG. The multifocal ERG results in our patient supported that permanent visual loss following commerciality may occur due to permanent loss of photoreceptors. Home message. Multifocal ERG is known to be an objective tool that has been used to assess retinal function in various macular disorders as age-related macular degeneration, diabetic retinopathy, macular hole, retinal vascular occlusions, retinal drug toxicity, congenital retinal disorders such as Stargardt macular dystrophy, retinitis pigmentosa, and X-linked juvenile retinoschisis. Also, common use of multifocal ERG as a valuable tool for assessing the functional changes of the retina in patients after blunt ocular trauma, especially in cases that have medico-legal aspects. And we know we want to have an objective tool to confirm the complaint of the patient. Finally, I want to express my sincere gratitude to my supervisor, Professor Yoshiki Shimada, for helping me in this case during my scholarship to Japan, Fujita University in 2016. Thank you for your attention.
Thank you very much, Kariman. And
thank you for this opportunity.
We'll open the discussion. Dr. Musa.
Yes, thank you, Dr. Kariman, for this nice case. It's actually a very excellent and nice case and well presented. Personally, I had a couple of cases with small macular hole, traumatic macular hole, which is closed. And it's reported as you show us. And he was very lucky guy to close the hole. And the small hole, like 100, it gives you the impression that the trauma, it wasn't that severe trauma. So, and personally, I see if he was in small kids, in young patient, usually the hole, it's closed faster than others. And it's usually closed between 2 weeks till 1 year. But I have one comment in your OCT. The OCT that you represented, the quality, it was not that good. It looks like it's time domain OCT, not the spectral domain, I think.
I think yes, itself 5 or 6 years ago. I think so. Yeah.
Yeah, it was, but it's nice case actually. No comment in your case. Fantastic.
Thank you.
Super.
Thank you. Thank you. Thank you.
Thank you, Dr. Musa. So, Dr. Ala.
So I have to thank you very much for this nice case report and very well approached and treated. Just I have a case. Did you do any IR a picture or something like autoflu?
What? Sorry, can you repeat the question?
Infrared picture, just to see if there is any defect in the RPE.
No, I don't have any picture. It's 7 years or 6 years ago, and this is all the images that I have. I'm now in Egypt, not in Japan.
So it's very important to talk about MF-ERG in our practice, especially to detect cases which called unclear visual disruptions or something like so. That will help us too much in order to tell the patients why they won't be able to see very well, and there is permanent trauma in this, let me say, layers, which is not easy to detect with OCT or other normal diagnostic, let me say.
Yes.
So, but very well presented, very well approached.
Thank you for your attention.
Okay, thank you, Dr. Musa. Thank you, Dr. Alauddin, and thanks to Kariman as well. And now we can move to speaker number 6. Yusuf, are you with us?
Yes, I'm here. Can you hear me clearly?
Yeah, would you please start sharing your screen? Meanwhile, Dr. Rashid Sakhsoukh and Dr. Muhammad Abdullah will discuss with you. Dr. Yusuf will talk about updates and understanding retinal pathology through novel OCT descriptions.
Good evening, everybody. Thank you for having me, and thank you for the panelists for their time that they contributed to this discussion. My name is Yusuf Fad. I'm an assistant lecturer of ophthalmology at Ain Shams University, Egypt. And I'm going to make an argument for OCT and how it has revolutionized our understanding of retinal pathology in the recent years. So yes, recently we do have ultra wide field color or pseudo-color images, fluorescein angiography and autofluorescence, and that's very cool and everything, but it doesn't really tell us a lot about retinal pathology, a lot different story than the one we already know. But with OCT, the way it has surpassed through time domain to spectral domain and now swept source OCT, and it tells us a whole different story. And we now have a lot of insights about retinal pathology, and it has opened some doors to treatment of retinal pathologies as well. It has brought us closer to histopathology of the retina, I think. And in the next couple of slides, hopefully, I'm going to get you excited a little bit about the black and white images and sections of the retina like I am. And that's through giving you a couple of examples about how OCT has revolutionized our understanding of retinal pathologies in the recent years. So let's start with DME, which is the elephant in the room. One of the most common causes for ordering OCT, at least in our Arab world, where we have high prevalence of diabetes mellitus. And we used to think that DME is just one entity, hyperreflective spaces in the OCT, and you go for anti-VEGF and you hope for the best. Sometimes the patient responds, sometimes they don't. We didn't know the reason. But now through OCT, we understand that these are different pathologies. DME can come with all shapes and forms. It can be subretinal fluid, intraretinal fluid, with or without epiretinal membranes, with or without vitreomacular traction. And with high resolution OCT, we can now see other pathologies related to DME, like these hyperreflective foci, for example. And the number and distribution of these hyperreflective foci has been shown by multiple groups, like this publication by Dina Zor and colleagues, to relate to the outcome to treatment. So now we could classify and stratify our patients according to their response to therapy. And we can actually implement AI, which is already ongoing, and you can put in your scans of your patients, and it can tell you, integrate all the data I already mentioned, and tell you the predicted outcome of your patient, and maybe even select the best treatment modality for your patient. So customized therapy for diabetic patients. So moving on to another entity, retinal circulation. Fluorescein was useful to get some information about the retinal vessels and leakage and everything, but we couldn't segment at different layers of the retina, which is the advantage of OCT angiography. And through OCT angiography study, we understood that the retinal capillary plexuses are 3 layers: superficial, middle, and deep capillary plexus. And we used to think that they're arterial and venular on both sides equally. But newer understanding of retinal capillary plexus, now we know that the deeper you go into the retina, the more venular component you have of the retinal capillaries. And venules have slow flow of blood, so they're more liable to ischemia. And that's why the ischemic cascade starts in the deep retina around the outer plexiform layer. And these are PAM lesions, or paracentral acute middle maculopathy, which David Saraf described back in 2014. And these are warning signs for ischemia. So the lower image is actually one of my patients at our university hospital, cataract candidate, and we do pre-op evaluation, and you can see the fundus looks pretty normal, a little bit hazy due to the cataract, but nothing out of the ordinary. We do OCT and we find these PAM lesions in the OCT, and the patient is presumably medically free. So we send him for medical evaluation, and the patient turns out to have uncontrolled severe hypertension. So this could be even life-saving, not just vision-saving. So how do these PAM lesions end up, these infarctions of the deep capillary plexus? They end up with atrophy and thinning. And Matthew Bachoum has beautifully described this thinning that occurs in the middle retina after PAM lesions and compensatory expansion of the outer retina. So you get this wavy appearance of the outer plexiform layer, which he called ripple or retinal ischemic perivascular lesions. And his group actually correlated the number of ripples to the cardiovascular risk factors of your patients. So how cool is that? You can look at an OCT of your patient and assess the cardiovascular risk factor and the risk of myocardial infarction in that patient. So moving on to the other elephant in the room, AMD. This is a dry AMD case, and we use the term atrophy all the time, but there's no consensus on what is atrophy. There are many terms: atrophy, nascent atrophy, incomplete atrophy, evolving atrophy. But now with OCT and recent OCT imaging, we can have a consensus definition of atrophy. And this is work by the CAM group, and they defined what constitute RPE and outer retinal atrophy, or RORA, which could be complete C-RORA or incomplete I-RORA. And when you have RPE attenuation, subsidence of the inner retinal layers, choroidal hypertransmission, this is RORA. If it's beyond 250 microns, this is C-RORA, and if it's below 250 microns, this is I-RORA. And this is pretty useful to have a standardized language so we can speak to each other and we understand the outcomes of clinical trials. But if your patient, if your patient is at this stage, you probably don't have much to offer. So can we predict which eyes are going to go into atrophy using OCT? And the answer is again, yes. This is work by Dr. Vassada's group, and they showed there are OCT biomarkers that can predict atrophy. And I think this is pretty relevant because we have newer drug therapies that can slow down atrophy that have already been approved or are about to be approved. So if you have a high drusen load, hyporeflective course of your drusen, if you have pseudodrusen, or if you have pigment migration into the retina or a thin double layer sign, that's all predictive of atrophy. You can know if your patient is going to go into atrophy, and you can counsel your patient at least or offer enrollment into clinical trials or newer therapies. So another relevant point to dry AMD is that we now have OCT almost everywhere. And we started seeing this fluid in in eyes without neovascularization. So dry AMD is not always dry. Sometimes you have fluid and you don't have neovascularization. And our group recently outlined this non-neovascular fluid in a Retina editorial that came out last month under the supervision of Dr. David Saraf, and it showed that you can have fluid in eyes with dry AMD, and it's not a good idea in these eyes to start injecting. So not always, don't have this trigger movement whenever you see fluid on OCT and you go for injection. We actually, our group introduced the protocol of observe and extend. You observe and extend the periods. So dry AMD is not always dry. And guess what? Wet AMD is not always wet as well. We have widespread OCT angiography everywhere now as well, and OCT angiography can pick up this neovascularization without exudation. So you don't have fluid in the retina, you don't have symptoms, you only have these neovascular components only detectable by OCT angiography. And you have to keep a close eye on these patients because they can progress to neovascular exudation. So you can pick these patients early on, and you can detect them early with exudation and treat them and prevent visual damage in them earlier on. And another entity that's relevant is pachychoroid disease. Pachychoroid disease, we used to all know about CSR, but now we understand it's a spectrum. Through novel OCT technology, we understand it's a spectrum of disorders. You can get form thrust CSR, which is pachychoroid pigment epitheliopathy, without any fluid, or long-standing pachychoroid, you can get neovascularization, pachychoroid neovasculopathy, or PCV, polypoidal choroidal vasculopathy, and you can get a variant of pachychoroid that's only around the optic disc, what we call peripapillary pachychoroid syndrome. So we used to see these drusen in younger age groups and think this is not AMD. And we now understand that at least some of these cases are related to pachychoroid. The pachy vessels are pressing on the choriocapillaris and impairing the blood flow to the RPE, causing accumulation of either drusen, what we call pachydrusen, or vitelliform lesions, what we call pachyvitelliform lesions. And speaking of vitelliform lesions, OCT has uncovered a lot about vitelliform lesions as well. We now know that these yellowish deposits in the fovea can occur not only with congenital or hereditary disorders like pattern dystrophy or Best disease, they can occur with anything that causes stress on the RPE, like pachychoroid disease or like epiretinal membranes. And these vitelliform lesions by OCT studies have been shown to always or almost always end up with breakdown and atrophy. So this is really relevant to your patient and the counseling of your patient and prepping your patient even for anterior segment surgeons, for example, going for cataract surgeries. So myopia is another forefront where OCT has been really useful, especially with wide field imaging, when OCT has really showed us the appearance and the configuration of the posterior pole of the eye, and the myopic maculopathy, for example, dome-shaped maculopathy, and for example, abnormal vitreomacular adhesion and epiretinal membranes, where you get a lot of cases with foveal distortion and visual affection. So another forefront of OCT is uncovering retinal layers that we used to not be able to image. Now we can image with very high resolution, and we can see layers that we only read about in pathology, retinal pathology books. For example, the Henle fiber layer, this layer that surrounds the fovea and is just an intertwining of the axons of the photoreceptors and the Muller fibers, which are obliquely oriented around the fovea and can get all sorts of pathology. So with pathology in the Henle fiber layer, you get this distinctive angulation and hyperreflective lesions, what's now known and what was recently published as the ASH sign, or angular sign of Henle fiber layer hyperreflectivity. And the lower images are a couple of my own cases with traumatic maculopathy, and you can see these oblique hyperreflective lesions related to the Henle fiber layers, and most of these end up with photoreceptor defects and leave a visual impairment of the patients. And finally, I'd like to talk about basilar layer detachment. We now understand through OCT imaging studies that you can get fractures within the photoreceptors, and you can get this special compartmentation of fluid between the external limiting membrane above and the ellipsoid zone. So within the photoreceptors, you get fractures of the myoid zone and fluid accumulation within. We don't really understand the prognostic significance. There are a lot of studies going on, but we do know they occur with a lot of different retinal pathologies. These are a couple of images from our recently published papers about basilar layer detachment. The one above is related to a VKH case we had, and you can see the huge basilar layer detachment. And the one below is related to choroidal tumors with basilar detachment. And this is a choroidal melanoma. And you can see with the blue asterisks, the basilar layer detachment in this case. So yeah, thank you for bearing with me. And I hope I got you a little bit excited about OCT like I am.
Thank you, Yusuf, for being on time. And now I'll open the discussion. Dr. Rashid.
السلام عليكم. تسمعني أستاذ سنجاب؟
نعم وعليكم السلام.
شكرا على الاستضافة. أنا أتكلم فرنسي، المستوى الإنجليزي عندي متوسط، ولكن لم يمنعني أن أتابع الإلقاء للزميل. هناك احترام للوقت. بالنسبة للبريزونتيشن كويسة، كل السلايد كلهم بالإيكونوغرافي، ما فيش نص، يعني هناك مستوى مرتفع لإلقاء لمدة 15 دقيقة بدون نص، يعني مستوى إكسبير. الإيكونوغرافيا أنا لاحظت الريفيرونس 2022 2023، يعني إيكونوغرافيا جديدة جدا، وكل الإلقاء يعني داكتواليتي، يعني جديد. حقول يعني خلاصة دا إكسبير ومش يونغ. كويس.
I was about to ask him, are you sure you are young ophthalmologist?
I'm only 30 years old, so hopefully, yeah.
So you have no comment, Dr. Rashid?
Yeah, كويس. Very good.
Fine. Okay, great. Now, Dr. Muhammad Abdullah, please.
السلام عليكم. شكرا دكتور يوسف على المحاضرة الرائعة for this great lecture. Thank you for the amazing picture you gave to us, and I want to share the whole message we'll take, that the OCT and the OCT angio is in its beginning and the future for OCT angio. And I would like to give another home message. OCT and the OCT angio not only explain us when to start the treatment, but it explains us the most important when to stop the treatment and when to not to inject. As you show in the fluid in the dried age-related macular degeneration. And I would like to explain to us the degenerative cyst in diabetic macular edema. What's the character in diabetic macular edema to stop injection in it? What its character?
Yes, exactly. So OCT is really useful to pick up these cases where it's not useful to inject anymore. So not all hyperreflective spaces in the retina deserve injections. So some of the hyperreflective spaces could be related to degenerative cysts, for example, in either DME or even AMD. And these, how to know whether it's degenerative or exudative, I think what's been published before is that degenerative cysts are more related to the middle retina because they're related to the molar fiber degeneration. So you get these degenerative cysts mostly within the middle retina. They're also related to areas of atrophy. So if you have atrophy and you have overlying cystic spaces, hyperreflective spaces in the retina, that's mostly degenerative. And the final thing, and I think the most important thing, is you keep an eye on them, and if they're growing or increasing, that's exudative, and if they're stationary or remaining the same, so that's definitely degenerative, and you don't need to over inject your patient, especially because anti-VEGF, although it's a small risk, but still have some systemic and local side effects that can happen.
Thank you, Trish. Thank you.
Yusuf, you should stay among panelists. It is one of the best presentation I have attended, really. So it's a high level of presentation. I have learned a lot from you. Thank you very much for this nice and well presentation.
Thank you. That's very humbling. Thank you.
Thank you, Yusuf.
I have also the same point of view.
Thank you, Dr. Muhammad Abdullah, Dr. Rashid, for the discussion, and thank you, Yusuf. And to be fair, I have to mention that Kariman, Kariman, are you still with us? Speaker number 5. Kariman. The previous speaker, I have to be fair.
I'm with you.
Yeah, I have to be fair to mention that also your presentation, you had no references at all.
Oh, yeah.
All right. Okay. So now we can move to speaker number 7. Khalid, are you with us?
Yes, doctor.
Dr. Mazen.
Yes.
Can I comment on references? Just, I mean, there is, I mean,
No, please don't give any hint,
yeah.
because we are going to talk about everything. Inshallah,
Yeah.
we are going to talk about everything after we finish this episode, the rest of the sessions as well. Okay. Thank you very much. I really appreciate. Now, yeah, Mr. Dr. Khalid, you can. Okay, you are sharing your screen. So Dr. Khalid will be discussed with Dr. Suzanne Amana and Dr. Alauddin Abdin. You will talk about white retina. So would you please start?
Okay, good evening. Today we have a case presentation of white retina. Our case is a male patient, 36 years old. He is not diabetic, not hypertensive. He complains of blurring of vision in both eyes, especially when wearing his mask. This was noticed 10 days after an attack of common cold. On examination, his best corrected visual acuity was 1 in the right eye and 1.2 in the left eye. Anterior segment examination was unremarkable. Pupils were active directly and consensually in both eyes, and his IOP was 16 in both eyes. On fundus examination, there was bilateral whitish discoloration of retinal blood vessels in both arteries and veins. Fluorescein angiography was unremarkable. The same night, the general condition of the patient was deteriorated and he was admitted to the ICU. He was diagnosed of acute pancreatitis. As we can see, there is hypercholesterolemia and hypertriglyceridemia. Regarding hypertriglyceridemia, its ocular signs include xanthoma, xanthelasma, and corneal arcs. It may begin to present as early as serum triglyceride of 1000 mg per deciliter. Lipemia retinalis is often not noticed until triglyceride levels reach 1500 mg per deciliter. Demography: 1.7% of US population were estimated to have severe hypertriglyceridemia from 500 to 2000 mg per deciliter. They tended to be men, non-Hispanic, white, and aged from 40 to 60. Diabetes and hypertension were associations of hypertriglyceridemia. Its causes: primary cause is familial chylomicronemia syndrome. Its pathophysiology include deficiency of lipoprotein lipase or presence of its inhibitor of the lipoprotein lipase or deficiency of its apoprotein. Secondary causes include diabetes, endocrine diseases like hypothyroidism or metabolic syndrome, medications like corticosteroids or beta blockers, pregnancy, renal disease, liver disease, dietary intake high in saturated fats and carbohydrates, systemic diseases like HIV. So, our case was diagnosed as Lipemia retinalis. It's a retinal manifestation of hypertriglyceridemia, not hyperlipidemia. It's characterized by pink to milky white discoloration of retinal vessels, which starts in the peripheral retina in cases when triglyceride level reach from 2500 to 3500 mg per deciliter. When it involves posterior bole, when triglyceride level reaches from 3500 mg per deciliter to 5100 mg per deciliter. And now we can only differentiate between the retinal arteries and the veins by their caliber. When the triglyceride exceeds 5000 mg per deciliter, the fundus takes the salmon color. Why do we see this appearance? Why? Because there is light scattered by the chylomicrons. Diagnosis is mainly clinical. Lipemia retinalis is typically asymptomatic and does not affect visual acuity except if associated with vascular occlusions or retinal ischemia. Chronic hypertriglyceridemia may manifest with abdominal pain. Why? Due to acute pancreatitis. Also, fasting lipid profile can help us, and usually fluorescein and ICG are not remarkable. OCT shows engorged hyperreflective retinal vessels, inner retinal changes, especially in inner nuclear layer and the ganglion cell layer, which may slowly disappear several months after triglyceride level are normalized. On the other side, the gross milky white appearance of the retinal blood vessels, which is seen clinically, and its hyperreflectivity disappears just 5 days after the control of triglycerides. So now we can see that not only the diagnosis is clinical, but also the prognosis is clinical. Treatment of Lipemia retinalis is a relatively easy treatment of a life-threatening condition. The patient here is liable to all systemic and retinal vascular pathologies. Treatment should be directed to lower triglyceride under 500 milligram per deciliter. Fibric acid derivatives, niacin, omega-3 fatty acids, and the high dose of statins can be used. Statins can reduce triglyceride level up to 50%. Modification of lifestyle is required. Regarding infantile Lipemia retinalis, breast milk should be stopped. In severe cases, we can try plasmapheresis and ileal bypass. And now we can see the change of fundus appearance after control of hypertriglyceridemia again and not hyperlipidemia in both eyes. Differential diagnosis: vascular occlusions, either branch or central, hypertensive retinopathy, diffuse choroidal hemangioma. The tomato ketchup fundus seen in patients with diffuse choroidal hemangioma may resemble salmon fundus in the third stage of Lipemia retinalis. Lipemia retinalis in literature, Lou et al. Reported decreased A and B waves amplitudes in electroretinography in both rods and cones. Reversal of ERG changes was described after triglyceride control. Interestingly, in 2021, Lei and Chang suggested that the absolute serum triglyceride may not be the sole determinant of the typical appearance in Lipemia retinalis. In spite of this, early detection that leads to timely treatment will assist in prevention of severe ocular and systemic vascular complications. In 2022, Al-Sarhani et al. Reported significant alteration in retinal oximetry in untreated Lipemia retinalis and also in resolved. The increase in retinal blood flow and oxygen saturation may explain the good visual acuity in Lipemia retinalis, in contrast to other retinal conditions like CRVO, where oximetry is low to very low. Our take-home message is that a quick fundus examination of a patient with perfect best-corrected visual acuity can save his life. And further research should be directed towards factors helping normalization of the fundus appearance in Lipemia retinalis. And these are my references. And at the end, I would like to thank my professors for giving us their precious time. Thank you.
Thank you, Khalid. And now we will open the discussion. Dr. Suzanne Amana, would you please start?
Okay. Thank you, Dr. Khalid. Very nice presentation. Why your camera is not working? We'd like you.
I just forgot from stress. I'm sorry. I just forgot to wait from stress. Okay. Now it's working now?
Nothing.
Still not working?
No. I expect a title, White Retina. I will hear about retinal ischemia, but maybe you use this title يعني خلينا نقول is a misleading one Why you choose white retina?
Just to make the topic more interesting for audience, not more. I know it's white retinal vessels, not white retina.
Okay. Can you explain to me the role of OCT angio here in the diagnosis or in differentiate the lipemia retinalis from other causes of white vessel, retinal vessel? Is there any role for us?
Up to my knowledge, there is no role of OCT angio because it's not like CMV or something. It's mainly hyperlipidemic state. I did not find any paper mentioning OCT angio as valuable in lipemia retinalis.
I don't agree with you, Dr. Khalid. OCT angio, as you mentioned, there is normal blood flow, normal retinal vessel density in lipemia retinalis. So you can differentiate by OCT angio from other etiology that cause depressed vascular density, reduced vascular blood flow, like in hypertensive retinopathy. So it can differentiate. It has a rule.
Okay.
Okay.
Thank you. Thank you.
Okay, thank you. Thank you.
Thank you, Dr. Suzanne. Dr. Alauddin Abdin.
So thank you very much for this nice presentation for a relative uncommon disorder. I'm also the same point of view. White retina, I don't find it a very nice title for this topic. Maybe if you put it like white vessels, retina vessels, not always ghost vessels, something in this direction could be better. Another important things, I want to thank you for putting the visual acuity in decimal in the first slide. That's very nice because it could be more international and more common for some societies. And I have also small notice about the references. The references, you had to put the references in the first part of the slides. You put it just at the end of the discussion. It was actually good references, new references, but I would like to see the references from the beginning also. Otherwise, it was well presented.
Thank you.
Thank you, Alauddin. Now, regarding the references, it's a long story that we are going to talk about it, inshallah, at the end of the episode 1, when we give advice, a lot of advice to our young ophthalmologists, including the referencing. Now, there is a question, since we have 1 minute, why the patient had reduction of vision during wearing a mask?
Yeah.
It was just the complaint of the patient, which should be mentioned in details by the patient language, not a doctor language.
Okay, but there is no correlation. Scientific.
No.
Okay.
Thank you.
Okay. Thank you, Yusuf. Thank you, Dr. Suzanne Amana, Dr. Alauddin Abdin. And now we can move to speaker number 8. Are you with us?
Yes, Doctor.
Okay, speaker number 8 is Sahar. We'll talk about retinopathy of prematurity. Dr. Rashid Sakhsoukh and Dr. Musa Al-Fuqaha will discuss with you. Please
is the
start.
PowerPoint shared?
Yes, it is. You can start your presentation, please.
Yes. Bismillah ar-Rahman ar-Rahim. Today I'm talking about retinopathy of prematurity, ROP. My name is Dr. Sahar Masmari. I have serial import in ophthalmology. So what is retinopathy of prematurity, ROP, and why we talk about it today? Is a proliferative disease occurring in premature infant that affects blood vessels of the developing retina. ROP results in the development of vascular shunts, neovascularization, and the severe form from it is fractional retinal detachment. Despite being a treatable disorder, ROP is still the leading cause of childhood
visual impairment worldwide, epidemic in the low to medium income countries. First, let's talk about pathophysiology and what is the pathophysiology. For retinal vascularization, we know that it began centrally from the optic disc and by the 16 week of gestation. It reached to the posterior pole 22 weeks of gestational age, to the nasal serrata by 36 weeks, and finally to the temporal ora serrata by 40 weeks gestational age. So ROP results from abnormal growth of these retinal vessels in the prematurely born infants. So normally in fetus, the fetus in the uterus is in hypoxic environment where the concentration of oxygen is only 22 to 24. This hypoxic environment stimulates vascular endothelial growth factor or VEGFs that stimulates also retinal vessels growth into the peripheral avascular retina. So by the first term baby, the concentration of the oxygen change and start to increase by delivery to 70, 80, which stop the stimulation of the VEGFs. So low tissue oxygen mean more VEGFs, the hypoxia mean less VEGFs. Like we said, the normally growth of retinal vessels where there is a normal VEGFs, in the premature birth baby, the vessel of the vessel growth stops in suddenly by the changing of these environments, and the VEGF stimulation stop. So there is less of the VEGF secretion. By maturing the retina and the needs of the retina increase, it starts to have a hypoxia, so it starts to stimulate more VEGFs. These VEGFs, of course, leads to retinal neovascularization. The retinal neovascularization either have a normal vesicle growth in the retina, which mean the resolution of ROP, or it can lead to a quickly and a very poor quality vessels, which lead to proliferative retinopathy and retinal detachment. So the risk factor for ROP is the premature birth infants with 30 weeks gestational age, low birth weight, 500 gram, oxygen supplementation or fluctuation, or in ICU incubation. The classification of ROP is dependent on location. We consider as zones, severity, stages, characteristic of the vessel in the posterior ball, we call plus disease, and the extent. For location, we have 3 zones. Zone number 1, it's a circle centered from the optic disc, radius equally to twice distant from the center of the disc to the center of the macula. Of course, clinically with the 28 diopter binocular indirect lens, only zone 1 is seen if any part of the optic nerve head is visible. So zone number 2 and 3, it's are based on convention rather than strict anatomy. So zone number 2 is from the border of zone number 1 to the nasal ora serrata, and its radius equal to the distance from the center of the optic disc to the nasal ora serrata. Zone number 3 is the residual crescent anterior to zone number 2, or it's the temporal ora serrata. For stages, we have stage number 1. Stage number 1 is a line between the avascular zone anteriorly and the posterior vascularized retina. We call it demarcation line. Stage number 2, it's when this line have a height and width, we call it stage 2, we call it ridge. And always the easily see line is always stage 2, not 1. When we have neovascularization, we consider it as stage number 3. For we have a subtotal retinal detachment, either with extrafoveal retinal detachment 4A, or with including the fovea, we call it stage 4B. The stage 5 is total retinal detachment. Either it's stage 5A, the open final retinal detachment, or closed final retinal detachment. We can differentiate between them by looking to the disc. If we can see the optic disc, it's open final. If we cannot see the optic disc, it's closed final detachment. Stage number 5C, it's a category where stage 5B plus the anterior segment changes. The plus is defined by the appearance of dilation and dilation of vessel tortuosity, plus or minus vitreous haze, and plus or minus papillary engorgement. The aggressive ROB, or early known as rush disease, it's a severe type, rapidly progressive form of the ROB, were usually located in the posterior zone 1 and zone 2. So if we notice the severe the IOB, we have higher stage numbers, lower zone numbers, and plus disease. Screening and diagnosis, it's recommended that infants with the following characteristics be screened for ROB. First, gestational age of 13 weeks or less. Some studies suggest that 34 weeks. Birth weight 500 gram or less. And also some studies suggest that 2,000 gram have to be screened and examined, or complicated clinical course like in ICU, oxygen supplementation, or hospitalization more than 28 days. What we need for screening and diagnosing the ROB? Actually, we need speculum, indirect ophthalmoscope, scleral depression, and papillary dilation. So it's simple, it's safe, it's non-invasive, it's valid test. For treatment, approximately 10% of infants examined for ROB require treatment, either with anti-VEGFs, retinal ablation, cryo or laser. These for stages from 3 or less, stage 3 or less, and scleral buckling, vitrectomy, lens severing, or with lensectomy. This is for stage 4 and 5. End of treatment, either with spontaneously or after treatment. The first sign is complete vascularization, where the vascularization into the peripheral avascular retina reach to 1 disc diameter of temporal ora serrata, or regress the ROB area by thinning and whitening of the new vascular tissue. We consider it as no active disease left. So what is the take-home message? The take-home message from this presentation is, in the past few decades, neonatal care has developed significantly. Nevertheless, the ROB is still the leading cause of childhood visual impairment worldwide. Approximately 3,000 infants worldwide diagnosed with irreversible vision impairment due to ROB. More than 20,000 blind or severely visual impaired. The most important aspect in ROB prognosis is preventing it before it progresses to an advanced stage. ROB screening and treatment is highly beneficial for quality of life, cost saving, and cost effectiveness. And screening of preterm infants will be the key to preventing a devastating long-term effects for severe ROB. In advanced stages of ROB with retinal detachment, the treatment is always surgically, and the visual outcome is usually very poor despite the successful anatomical retinal attachment. Therefore, preventing ROB progression by timely screening, examination, and treatment remains the most important part of ROB management. And the conclusion of greatest importance is the finding that probably time screening and treatment for ROB is not only cost-saving, but may save infants from a lifetime of blindness. And thank you. This is my reference.
Mm-hmm. Thank you very much, Sahar. Now I'll open the discussion. Please, Dr. Rashid.
السلام عليكم. سحر. لتقييم هذا البريزنتيشن أبدأ بالوقت. هنا عملت 9 دقائق و40 ثانية مقابل 15 دقيقة. بالنسبة للإلقاء فيه نص، يعني السلايد شارج بالنص، ولكن فيه إيكونوغرافي كويس. بالنسبة للمحتوى كويس، يعني كل ما يقال على لا ريتينوباثي دي بريماتوري ما فيش ريفيرنس، ما عملتش ريفيرنس. وبالنسبة للبراكتيس، هل عندكم حالات لل ريتينوباثي دي بريماتوري؟ لديكم حالات؟
Unfortunately, we don't have. We see only the complication. We see only the children with the 1 year or 2 year with the total RD and very poor visual acuity. So my point from this PowerPoint is to highlight that there is a lot of cases of ROB, but there's no, there's like I said, no one care about it because we are in a poor country. Usually they said if you are in a poor country, there's no ICU care, so we don't see ROB. And this is totally wrong. We see the complication of ROB many times in our countries.
ما تعملوش وقاية ب examination للخدج؟
Unfortunately, in my city, there's no program for screening.
شكرا.
شكرا دكتور رشيد. دكتور رشيد، ملاحظة هو ال presentation is 12 minutes not 15 and 5 minutes for the discussion, so the comparison is with 12 minutes. Okay, and now Dr. Musa Al-Fuqaha, please.
Yes, thank you, Dr. Mazen. Thank you, Dr. Sahar, for your presentation. You did not told us in your presentation when to start to examine those babies. For example, you have baby which born today. When we should start to examine? This is the first thing. The second thing, the laser is the treatment for those patients. But from my practice, you start to examine the patient and you see the pupil is not dilated, is narrow pupil. And as much as you put all the drop mydriatic, the pupil is still. So what do you think? What you have to do in this case? How you have to treat this patient? Because you cannot do the laser for this. So 2 questions.
First, about the first question, the screening starts from 4 weeks after the delivery. Of course, there is a lot of about if the baby reach maybe 32 weeks after its gestational age, and but in short term, it's easily to remember. It's 4 weeks after birth. This is how. Yes. Yes. About the second question, actually, I don't have very much experience in the treatment of these children. When I read about it, most of study now changed to treat it with anti-VEGFs because of the a lot of complication for laser and the cryo. From the high MIO, from the amblyopic, from the strabismus. So most of the study now changes to start to use anti-VEGF. And truly, it's very easy for us as a poor community, if I can say, where I live. It's easy to have anti-VEGF rather than the laser or the cryo specified for neonatal.
Let me just add something that the anti-VEGF is not a treatment for ROB. So anti-VEGF will not prevent the patient or the baby from developing the retinal detachment. The laser is the gold standard for treatment now. And we don't have till now, the studies showing us the effect of anti-VEGF in these premature babies. Don't forget these premature babies, and we using anti-VEGF. So there is not too much studies showing us what the effect of this on the babies. It can improve the refractive issues in those babies, but will not treat them. So if you have a baby with myosed pupil, you cannot do laser. You can start with anti-VEGF. After 1 week, you will see the pupil will dilate it and you can do your laser.
Yes, thank you. Thank you for your note.
Thank you.
And about my reference, I put my reference at the end of the last slide. I put my reference actually.
Yeah, correct. All right. So now we can move. Thank you, Sahar, and thanks to Dr. Rashid and Dr. Musa. We can move now to the last presenter. Noor, are you with us? Yes. Would you please start sharing your presentation? Okay. Noor is going to talk about diabetic retinopathy challenges in diagnosis and treatment. Dr. Muhammad Abdullah and Dr. Alauddin Abdin will discuss with you your presentation. You can start now, please.
Assalamu alaikum jami'an. I would like to thank you very much for this opportunity and thank my professors and panelists for listening for me. I'm Noor Shobaki. I'm fellow in veterinary department since 2020. I would like to talk about diabetic retinopathy challenges in diagnosis and treatment. We know that the diabetic retinopathy has a risk of blindness among patients aged between 25 to 74. By 2030, an estimated 190 million people globally will have diabetic retinopathy and approximately 56 million will have a vision-threatening diabetic retinopathy. So we have to know also the pathology of diabetic retinopathy, which is either by capillary leakage, capillary occlusion, sequelae of retinal ischemia, by vascular endothelial growth factors, which is secreted by ischemic retina that leads to either increased vascular permeability resulting in retinal swelling or edema, or angiogenesis and new blood vessels formation. The classification of diabetic retinopathy and macular edema according to ICO classification, either no apparent diabetic retinopathy, mild non-proliferative, moderate non-proliferative, severe non-proliferative, and proliferative stages. In mild stage, you will see just microaneurysms. In moderate, you will see microaneurysms and blood and dot hemorrhages. In severe non-proliferative, like a moderate, but also we have an venous bleeding and intraretinal micro abnormalities in all quadrants. The proliferative stage, like the severe, but also we have an adding by new vessels, either on the disc or new vessels elsewhere, or tractions in advanced stages. The diabetic macular edema also classified as either non-diabetic macular edema, non-central involvement diabetic macular edema, central involvement diabetic macular edema, also according to the central subfield zone that is 1 millimeter in diameter. Here is a notification about hard exudation, which is an indication for chronic macular edema or recurrent macular edema, and actually it's very hard to be treated. The diagnosis of diabetes depends on clinical examination and on helpful tools. The clinical examination, a good history, full anterior and posterior segments examination are mandatory to reach for the diagnosis and consequently a proper treatment. The helpful tools, the most important tool is the OCT, which is useful to determine the presence and location of edema and subretinal fluids, as well as retinal thickness. And it's used on the diagnosis of the patient and then with the follow-up visits before injection, after injection, and so on. The fluorescein angiography is the second helpful tool, which is used to determine the degree of ischemia of the, or the presence of retinal vascular abnormalities. And it's useful to see the severity of ischemia. So we will talk about the challenges in the diagnosis of diabetic retinopathy that we face in our clinic work. The first one is the history misleading, difficulty to differentiate between diabetic retinopathy and other causes of the same pathology. For example, to differentiate vitreous hemorrhage that's caused by diabetes or trauma, retinal tears, or either vein occlusion. The second challenge is the laterality. One of the most common misdiagnosis issues is the difference grades between the two eyes. So the same grade must be present in both eyes. If you see a mild non-proliferative in one eye, it will be a mild non-proliferative, or even one stage between two eyes. The third one, false undergrading of classification, can occur by inappropriate peripheral examination. The fourth challenge is the presence of other pathology. If there is a dissimilarity between the two eyes in staging, you must look for other pathology like ocular ischemic syndrome or vein occlusion. So if you see this picture, when you see, for example, the right eye has, or the left eye has mild non-proliferative diabetic retinopathy, and you're sure from that, and see this picture in the other eye, you will say the diagnosis is mild non-proliferative diabetic retinopathy, superimposing by central retinal vein occlusion. The challenges in the treatment of diabetic retinopathy, the first challenge is the lack of awareness about the disease and its complications and vision-threatening effects. So patients not come to visit ophthalmologists except in advanced stages of the disease. The second one is the difficulty in accepting the way of the treatment because of wrong ideas about some modalities of management. If you say for the patient, I would like to inject your eye, he will say, oh, you put an injection in my eye, or you will burn my retina by laser. There is a wrong ideas about the treatment modalities here. The third one is the lack of capabilities in remote areas and the inaccessibility to the cities that provide a service for vitreoretinal subspecialty. The fourth one is the diabetic retinopathy cases are not promising in their results. Not like a phaco or LASIK, you will see the patient second day, he has a 6/6 in his vision. And the high costing of retinal surgeries, also a very important challenge for us here. I have here some solutions or suggestions. First one in the diagnosis to take a good history about the duration of diabetes, which is a very important risk factor, the severity of decreased vision, how long the duration of decreased vision, history of trauma, history of myopia. And myopia is very important here because it's a degenerative and ischemic state of the retina, and the diabetic retinopathy will appear later on. The second one is a good examination. If you doubt about the diagnosis, the grading, or the presence of other pathology, you must refer the patient to the vitreoretinal department. For example, for patients complaining of floaters, must be examined very well, especially if there is a history of diabetes to exclude vitreous hemorrhage. The third is the medical workup with endocrinological cooperation. The treatment suggested solutions by first one, raising awareness about diabetes and the possible complications, good consultation for patients for the importance of follow-up visits, reassurance for patients, even those with advanced stages of diabetic retinopathy. The fourth one is the good explanation for the patient about the appropriate management of his stage of the disease. Here is some studies done by Professor Mahfouz, Professor Saleh Al-Aqili, Professor Junaid in November 2011 about the causes of visual impairment and blindness among Yemenis with diabetes. They found that many causes of visual threatening effects. The first one and the most common one was cataract, and it's a preventable one. Diabetic retinopathy, diabetic maculopathy, proliferative stages, ischemic stages, glaucoma, and finally retinal dystrophy, and it's the least percentage. The authors here found that around 50% of visual impairment and blindness is preventable by early detection and treatment of proliferative retinopathy and macular edema. They said that early detection, laser treatment, intravitreal injections, either bevacizumab or triamcinolone, are key factors to prevent the decreased vision and decreased blindness from diabetes. Also, they said that screening programs reduce the number of patients losing their vision, and also physician training diabetic patients should be educated to refer their patients for early diabetic eye screening. My home message today is to know the risk and pathology of diabetes on the eye well. Full patient examination must be done. If you in doubt, not be embarrassed to refer him to specialists. Promote awareness about diabetic complications in your clinic. And finally, be patient with patients. Every patient needs reassurance and support to help them to alleviate their doubts and fears. And this is my reference, and the main reference for me is my patients and daily work. And I would like to thank my mentor, Dr. Abdurrahman Al-Hamadi. He is my senior. Thank you very much.
Okay, so thank you very much, Noor. Now I'll open the discussion. Dr. Muhammad Abdullah, please.
Thank you, Dr. Noor, for this nice presentation. هو الأول بس هو احنا التشالنج اللي نقصدها حسب الليكتشر موجهة لمين؟ هل هي تشالنج للكانتري اللي هيعمل بلاننج للتريتمنت بتاع الدايابيتك بيشنت، ازاي يوفر امكانيات، ازاي يدرب دكتورز، ولا هي التشالنج للدكتور اللي هو يعني سبيسيفاي في ريتنا يعني؟ فتعالي بس معاكي اراجع شويه حاجات كده. هو الباثوفيسيولوجي بتاع ايوه. Let us took the first point. You simplify the pathogenesis of diabetes. Diabetic retinopathy is not only ischemic retina secrete anti-VEGF. It is not so simple. The anti-VEGF is one factor. There is multi-modal disease. May be ischemic, may be inflammatory. There is many mediators that cause diabetic retinopathy. That is the first point. Second point.
Dr. Muhammad.
Diabetic patient.
Will you please repeat
what your tools to treat a diabetic patient?
I don't listen. Didn't listen.
Noor. What are your tools to treat a diabetic patient?
Okay, the first one about the pathology, I summarized my
three tools.
Yeah.
You have anti-VEGF.
Dr. Muhammad?
You have anti-VEGF?
Here in Yemen, you said?
No, I'm just conveying the message. He was asking you or telling you. He left and then he will join. Maybe there is an internet.
Actually, I don't understand him.
Okay, no problem. He will come back and we'll discuss with you. Still, we have time because you finished 2 minutes before the time. Meanwhile, of course, I would like to kindly request from all the panelists to send me their evaluation forms, just the final mark for each speaker. No need for the detailed one, just the final mark. For example, if the speaker is me, Mazen, instead of sending 2 for this, 3 for that, 4 for this, you can just 18 out of 24 like that, please. Dr. Muhammad. Hopefully he will join. Meanwhile, if any of the panelists would like to discuss with Noor.
Dr. Suzanne raised her hand.
Yes, Dr. Suzanne, please.
Okay, Dr. Noor, a very nice presentation and important topic. Can you tell me in your country, when you use fluorescein angiography in certain situations, what are the situations that you use fluorescein angiography in diabetic retinopathy nowadays?
Actually, if there is an ischemia, doctor, in proliferative stage, mostly, to know the severity of ischemia, of hypoperfusion, of capillary hypoperfusion, a capillary dropout, and just we actually based on OCT for treatment our patients. And fluorescein, we will rarely use it, actually.
Right. You don't have, or you don't use focal laser photocoagulation. So under which guide you use?
Yes, in some cases, if we have to do focal laser, we guide it by fluorescein. Yeah.
Okay. So still we have for laser photocoagulation, and we use fluorescein angiography for detecting the leaking points. Okay.
Yes.
Retinopathy, or only for proliferative retinopathy. And sometimes we use for proper grading of diabetic retinopathy. You want to know if it is moderate, non-proliferative, severe, non-proliferative, okay?
Yes, so if we are in doubt, sir, we use it.
Okay, thank you so much, Dr. No.
Thank you, Dr. Suzanne, for your discussion. Now, yes, Dr. Muhammad, you are with us?
Yes,
please.
I told you you have 3 tools for treatment of diabetic retinopathy: anti-VEGF, laser, and surgery.
Yeah.
And the challenging or your enemy is persistent macular edema, proliferative vascular retinopathy, and this effect. What's their complication? Vitreous hemorrhage, proliferative tractional retinal detachment. When to use each one in each situation, this is the challenge. Anti-VEGF is used either to stop macular edema or is used either to stop vascular proliferation. Surgery is used either in resistant macular edema or in tractional retinal detachment. This is the challenging point to treat diabetic retinopathy. And the challenging point when to do surgery and when to stop to do surgery. What is the benefit for the patient and what is the harm for the patient? And thank you for your lecture.
Thank you, Dr. Muhammad. But I was talking about the challenges that we face in our clinic, how to deal with patients to reach the diagnosis, to reach the treatment, to make the patient accept our treatment. I don't talking about the disease itself. I'm talking about the challenges for us in our diagnosis and treatment.
Yes.
Okay, great. Thank you very much. The time is over. And at the end, I'd like to thank all the panelists for their valuable time and for being with us over the 2 hours. And those 2 hours actually were very interesting. So we couldn't leave our chairs even to drink a cup of water, because all the presentations were very interesting, and the efforts that all the speakers did and exerted was very obvious and clear. So thanks to the panelists and thanks to the speakers for being so brave and so keen to present. Of course, thanks to the audience as well. And hope to see you all next week with another session, which is general ophthalmology, that we will have 8 or 9 presentations as well. Have a good night, everybody. And I would kindly request from all the panelists, if they hadn't done the evaluation yet, to send it to me as soon as possible. And thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Shukran jazilan.
Thank you,
Prof.
Thank you very
I think
much.
there is only one comment from one of the audience, anti-VEGF is recently approved by FDA for ROP. So if any of the retina surgeons here would like to comment.
So in Europe, we used it as a standard treatment right now, not the laser.
For the ROP.
For ROP, the first line treatment.
Mm-hmm.
In Germany, at least.
In Germany, okay. How about you, Suzanne? Dr. Suzanne, in Iraq?
Yes, still, yes, okay. It's the first line treatment for prematurity, retinopathy of prematurity. Yes, I'm agree.
Dr. Rashid, how about your country?
ما عندناش حالات كثيرة لل ROP، ولكن الانتي في جي اف يعني علاج إذا لم يكن هناك استطاعة لعمل ليزر، يعني كويس قوي، لأن احنا عملنا انجكسيون يعني تقنية سهلة وكثيرة. هناك مضاعفات للار او بي لأن الشريط immature يجعلها immature، لكن كحل كويس.
Okay, great. Thank you very much and see you inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.